Previously in private practice with board certification in both family practice and emergency medicine, she's been working full-time in healthcare policy for the last 4 years. She obtained her MD from the University of Cincinnati College of Medicine, and she did a residency training at University of Wisconsin up in Madison. Dr. Haynes also volunteers as Senior Health Policy Analyst and Executive Board Member for Docs for Patient Care, as Executive Board Member of the Dr. Joseph Warren Institute, and is founder and president of the Black Ribbon Project, which promotes freedom of choice for patients and doctors. She previously served as National Co-Chair of Doc Squads, project to recruit and train doctors to lead the public health care debate. Dr. Haynes has published several op-eds on townhall.com, PJ Media, Huffington Post, and The American Thinker. Her research on cost shifting was instrumental to 2 amicus briefs submitted to the 11th Circuit Court of Appeals and to the Supreme Court on behalf of the plaintiffs challenging the constitutionality of the individual mandate. She frequently speaks to citizen professional groups on healthcare policy, the ACA, and the ethics and economics of medicine. So without further ado, I'll introduce Dr. Haynes.
So thanks for coming. I understand everybody's under pressure. We've got neuro exams, we've got step 1. I can't believe we have a third here. This is great. So thanks for coming. We'll try to keep it very much to a 1-hour talk. And I'm going to, half an hour and then a lot of time for questions and answers. There's way more stuff on this than I'm going to be able to cover, obviously, in half an hour. So what I want to do is at least introduce the topic to you guys and then deal with any questions that you might come up. And Sean's going to work the slides because we don't have a clicker. Okay. All right. So Benjamin Rush Institute has been around for about 4 or 5 years. I've only been with it for a little over a year. Benjamin Rush was one of 5 physicians who signed the Declaration of Independence. And since a lot of the point of view that we try and get across is really bringing us back towards some of those founding principles, individual rights, freedom of choice, that's what we chose Benjamin Rush as our figurehead for the Institute. Primarily what we want to do within our chapters on medical schools is open up the dialogue about the healthcare reform debate and keep the doctor-patient relationship forefront in that whole debate. I switched out of clinical practice into healthcare policy because I was very concerned about the recent trend that our country is heading with healthcare reform, and that doctor-patient relationship was not adequately considered in the laws that have been passed, and that there's some real downsides to that law and how it's going to affect the ability of doctors and patients to decide what is in the best interest of individual patients. So in order to understand how we got to the point of the current healthcare reform debate and passing of the law, and you can go on to the next one, we need to know how we got here. Why do we even have to have reform? Well, I think this country has some real problems in some very essential areas, that of access, affordability, and quality. There is no doubt that we need to improve our healthcare delivery system in the United States. There's a problem with that access, not only with the uninsured and underinsured, but I also think a significant portion of our population is overinsured, and that's contributes significantly to that cost rise factor. Because of all the uninsured and underinsured and the overinsured, we have gotten to a point where too many people are being priced out of affordable health care. This is a huge problem. It also affects quality. Now, I have some real problems with the data that is being presented by the World Health Organization, and if we want to get into that with the question and answer sessions, I'll be glad to do it. It's not the topic of this particular talk, but the ranking of the United States of 37th has some real problems with the data. In fact, 80% of the data of the World Health Organization that comes up with that is imputed data, which means it doesn't exist. They're taking similar places and then extrapolating. So it's based on 20% of actual data. Real problems with that. But we do, in spite of that, we do have problems with too high levels of medical errors. We have over and under treatment. We have a lack of continuity compared to the ideal that we would like, and there's variable practice standards. You guys have probably been taught about the Dartmouth Atlas studies. So the question that becomes part of this great debate is how much of the problems that we are facing in this country is due to the fact that healthcare really should not be part of a market at all, that it should be run as a public utility type system as most of the rest of the world does? Is it a market failure, or is it, go ahead, a government failure? Every single healthcare system in the world is a combination of markets and of government. Even Canada, which is the single payer, pays, those individual patients pay much more out of pocket than do patients in the United States. So 30% of their healthcare dollars are paid by the patient directly. The United States is closer to 10 to 14, depending on if you're looking at hospital costs or clinical costs. So even North Korea, which has the most government control of its healthcare system, has a market aspect to it. Now, it's a black market, but it's a market. Okay, so there is no system in the world that does not have a combination of government and markets. The question then that we have to answer is which is causing the problems and which is causing the success. Again, next we have to do is get to the bottom of that and understand how we got there. So the major themes of this talk are the laws and regulations that we have, and we've had for 160 years, that I think are actually artificially increasing the cost. So there's side effects. You as doctors are being trained in a way of thinking that is unique to be able to really solve this problem. If you come up with if we come up as physicians with a fabulous treatment for a tumor, and you give that chemotherapy and that tumor is totally decimated, but in the process, you wipe out heart cells, brain cells, bone marrow, and you basically kill the patient, you've done no good. You've been very successful at that target organ. So and if you put that into the system of looking at how we're trying to deal with healthcare, they're targeting certain populations, and they may be making real success with the uninsured, with the poor, with the elderly. But unless we look at how those interventions by the government are affecting the entire system, you're missing the big picture. So this is what we have to look at. Broaden our scope of view, make sure we're not looking at just who that target population and how they're responding, but how is it affecting the entire economy? How is it affecting everybody else? So that's it. That's a great way that we have a perspective, not just of what medicine is like and what that doctor-patient relationship is like, but another way of looking at solving problems. The other thing is that all these government interventions have actually worked to crowd out what I think of as true insurance. So, quiz on insurance. Next. Which of the following are actually insurance? How many would say Medicaid is a form of insurance? Okay, what about Blue Cross Blue Shield? Is that insurance? Okay. Anybody? Okay. HMOs, are those insurance? Okay. Medicare, is Medicare insurance? All right. Yeah. What about health insurance purchased through an ACA exchange? Is that insurance? High deductible health plan like the ACA, is that insurance? Okay. All state homeowners policies, is that insurance? What about progressive auto policy? Okay, next. And I'll tell you what the answer is. I would say the bottom two are actually insurance. The rest are different things, and we'll get into that. Before the ACA, what percent of healthcare was paid for by state and federal governments? 15%? Okay, what about 25%? How many think 25% was paid by government prior to the ACA? 50%. Okay, 60%? More, 75%. Okay, it depends on how you count it. 50% at least was covered by state and federal governments prior to the ACA. If you include the fact that there is lost revenue due to the exclusion of premiums for taxes, for income taxes, then we get closer to 60%. Okay, next. How many Americans do not have health insurance? 5%? 15? Okay, a lot of nods. 50? 90? Okay, I'm going to argue that 90% of Americans do not have health insurance, and that's because of the definition of insurance. I'm going to get to that. Go ahead. The purpose of risk pooling is to make health insurance more affordable. Is this true or false? True? False. Okay, a lot of questions. Great. So where did we start? Let's think about what medicine looked like 150, 200 years ago. We really didn't have a heck of a lot to offer. It's hard to see here, but this is the equipment that they used for bleeding people. The other way they did it was through leeches. There was a lot of patent medicines, which nobody knew the quality, and a significant number of them included mercury and arsenic. This is what the allopathic, which MDs are considered the allopathic tradition, this is what we had to offer people. They had a 50-50 chance of actually coming out better off and not harmed by an encounter with a physician 150 years ago. One of my favorite examples of a patent medicine is Dr. Miles' compound of extract of tomato. Once that got questioned by, actually it was the AMA, and said this really doesn't have any therapeutic advantages, the manufacturers of it changed it and we now have ketchup. Go ahead. Okay, so history of healthcare payment. In the we do not have a free market system in the United States. We have not had a free market system in over 150 years. The closest it ever came was prior to the Civil War. And that was when there were no effective licenses. There was competition going on between the allopathic, which ended up being the MDs, eclectic and homeopathic. The eclectic have disappeared, the homeopathic are a minor part of what's going on. There were a couple of others, the chiropractic and the osteopathics, that developed a little bit later, and they still exist to a significant degree within our system. But why don't we see it eclectic and homeopathic? Particularly since at the time, these two forms of healing actually were probably less harmful than allopathic medicine. The eclectics had plant-based drugs, digitalis, things like that. Rest and stress reduction were their main treatments. Homeopathics, in addition to these super dilute, probably pointless, but placebo effect medications, they also emphasized nutrition, hygiene, stress reduction as well. So people actually did better with those. But what happened? In 1847, the AMA and the allopathic physicians didn't like the competition. So they started working with state governments to push for licensing. And this started excluding some of these other methods of healing. In 1870, we had 175 doctors for 100,000 people, and in 1910, the Flexner Report came out. How many of you guys are familiar with Flexner Report? Okay, so this was a study that was commissioned by a nonprofit organization that was not associated with government, but what's little known is it was actually an AMA study that was almost completely taken and then applied. So the AMA was very, very heavily involved in influencing what that report stated. Once it was put into adoption, did we get better quality medical education? Absolutely, but at a cost. And that's what's really important to realize. Every intervention is going to have a side effect. You have to be alert to that. What was that side effect? They went from 166 schools, and by 1940 there were only 77. Because they were requiring 4 years of education. 2 years of textbooks, basic science, 2 years of clinical. Sound familiar? Okay, we haven't changed a lot since then. It also made medical education hospital-based. The highest tech, the highest cost, this is where we're now training our physicians. And only recently am I starting to see now, there's people saying, hey, shouldn't we be emphasizing out of hospital care? Shouldn't we have either, if not medical schools, at least residencies that are primarily clinic-based? Maybe we would have had that develop if the Flexner Report had not legally disallowed that kind of medical training. In addition, so that also drove down physicians to 146 per 100,000. That meant fewer doctors. If you decrease the supply, you increase what those doctors are making. So that helped preserve doctor compensation, but it drives up costs. You're pricing more people out of affordable health care. And which were the people that were getting excluded from medical training? Blacks, women, and Jews. It was a problem. So it was all white males after that. So in pre-World War I, the history of health insurance, we didn't have health insurance. Because people didn't think that health was insurable. There was no actuarial science that would inform people on how do you even set premiums. In order for insurance to work, they have to collect more in premiums than they pay out in benefits. And there was no way to predict that early on. So instead, what developed were these really neat grassroots projects called, and entities called friendly societies or mutual benefit societies. They're very local. They tend to be associated either with a job, an employer might start one, or an ethnic group, a religious organization, or something like the Rotary Club, things like that, Odd Fellows. They would have these mutual benefit societies. They would they would insure within each other. So everybody would pay a small premium. If someone got sick, then they would have somebody visit them, assist them in their home to try and help them get better, make sure they were actually sick, not malingering. So there was a variety of ways that there was some local control to keep those premiums effective and make it work. There was also straight charity. Individuals paid out of their pocket, and most sickness insurance actually covered lost wages, because lost wages was the biggest problem with getting sick. Medical care was extremely affordable at that point. In the Great Depression, of course, everybody had trouble paying for everything. And what happened down in Texas was there was a hospital. I'm sorry I'm talking so fast, but I want to get through all this. There was a hospital down in Texas that wasn't getting paid. They weren't going to be able to keep their doors open. So they made a deal with the Teachers Association for $6 a year. Each of your teachers pay us $6 a year. If they get sick, they get 3 weeks of hospital care without additional cost. This is not insurance. This is prepaid health care. That is the bulk of what we have today that we call insurance, is prepaid health care. So that was the beginning of the Blue Cross, and eventually the doctors formed their own associations of prepaid health care, which became Blue Shield. The Blues have dominated the healthcare coverage industry ever since. And part of that is, again, because of the government intervention. The Texas state government said, oh, this is great. If you keep this up, we won't hold you to typical insurance regulatory requirements. Not only that, we want you to stick with community rating, and I can talk about what that is if you're not familiar with it. And if you do that, and we'll grant you the nonprofit status, you don't have to pay taxes on your land, on any land, you don't have to pay taxes, that kind of stuff, which gives a legal competitive advantage to this business over other types of insurance, indemnity insurance. So with that advantage, they were able to outcompete other types of healthcare coverage. Then what happened in World War II, we had wage and price controls. There was no way for an employer to increase the wage to an employee in order to attract or retain that employee during World War II. So instead they started adding benefits. And one of those benefits was coverage for health costs. And then with the Stabilization Act of 1942, that it became official that those benefits would not be counted as taxable for income purposes. This gives a huge discount to the dollars that an employer spends on the to the benefit of the employee for healthcare dollars. And it's kind of an upside down subsidy, because the wealthier you are, the more of a discount you get. So if we were going to try and subsidize healthcare, this is exactly backwards to what we usually think we want to do, which is help the poorest, neediest the most. Because of this, this is why we are so overinsured. In fact, at certain income levels, an employer can spend basically $2 on health insurance for the same output that he's going to get $1 worth of wages. So it really drives and incentivizes spending much more on healthcare. And the only reason I put this thing out of place here, the FDA started in 1906, was a very interesting reaction that the world had to the thalidomide incident. Are you familiar with thalidomide? Those horrific pictures of babies being born with no limbs. So thalidomide was a drug that was used in Germany. It was never approved for use in the United States. And because of that thalidomide, this is what empowered confidence in the FDA to control the way we make drugs available to the market in the United States. What's fascinating about it is where the babies were actually affected in Europe and primarily in Germany. They had a very different response to that horrific experience. They'd just come out of World War II, and their experience of government and medicine coming together were the Nazis. they did not trust government to be able to handle anything to do with medical care. So they empowered their physician organizations and the pharmaceutical companies in order to be the ones to police the problems of quality of drugs. So it's just an interesting contrast of what different historical experiences and cultural expectations can do and how they can drive solutions to the very same problem. Actuarial science started developing, and so we actually were able to get some health insurance coverage. This is kind of a laundry list of other things, and I'm getting short of time because I want to leave a lot of place for questions and answers, but these are other interventions that we did based on the best of reasons. The hospital construction survey, there weren't hospitals in rural areas, so the government subsidized a whole lot of building of hospitals in rural areas to try and get people health care coverage because they didn't have access to it. But again, it's high tech, high cost. So they're constantly, we see government intervening and pushing the most expensive way of trying to solve the problem of lack of access. Gold exchange is a problem because that's where we started getting problems with inflation. Certificate of needs, they were trying to cut down the cost or the sort of an arms race of medical and capital equipment, but what it ended up doing was giving the already established people a leg up to say, no, we won't have any competition. They squelched the competition. HMO Act, people think of HMOs as a free market entity. It's not. It was subsidized and given a lot of legal advantages by the HMO Act of 1973. And then it drove costs so high, we got to the prospective payment system, and eventually we're at the ACA. So very quickly, I want to get to what I think insurance is. When I think of insurance, you're thinking of fire, auto, and life insurance. Next. It's a form of financing. It's protection against unlikely high-cost events, right? You don't pay for oil changes and even transmission replacements with your auto insurance. It'd be really expensive to do that. You don't pay for your lawn care with your homeowner's insurance. You don't even pay for a furnace replacement, which I did last year. That hurts. That's expensive. But I'm not putting my homeowner's insurance in it. I do pay for earthquake. I live in California. But it's unpredictable, not under the control of the insured. There is a reason that life insurance gets null and void if somebody commits suicide. That's under the control of the insured. How much of our health care is under the control of our insured? There's a lot, and yet it's covered. That's not really an insurable act. Premiums based on the risk of paying benefits. If you have a drunk driving episode, your auto insurance is going to go up. That's risk rating. Now, people are concerned that if you risk rate based on health status, that it's going to drive up premiums. It will, and yet what it also does is keeps the premiums low for people who make all the effort to try and stay healthy. Now, there's a significant portion of health problems that are out of the control of somebody. Nobody chooses cancer, and there's a lot of cancers that come up without any particular action on the part of the person. There are some market solutions for how to make premiums affordable, and there's reasons why you would want to have risk rating for the whole system effect, and I hope I'll have time to get to that. So, not insurance, Obamacare, the ACA, Medicare is not insurance. Medicaid is a pure wealth redistribution, but Obamacare and the HMOs are these prepaid health care, and Medicare is a lot of wealth redistribution. Wealth redistribution is a term I'm a little bit uncomfortable with, and because people can see that as a criticizing. I'm just trying to describe what actually happens, but it can be a highly politicized term for some people. So another way to think of it is cross-subsidization. And what is cross-subsidization? It's when a group that would normally not be paying much is paying more, so a group that normally would be paying more is paying less. So you have the healthy subsidizing the sick. The way risk pooling should work in a true insurance system is you're risk rated, you're pooled together with people of similar risk. What the risk is, they don't know who's going to get sick at what time, but they know what is the chance of that pool of people actually becoming sick. So you're all put together. It's not trying to average it out over everybody. Because if you average it out over everybody, there's no decrease in cost, right? But you're just charging some people more so you can charge some people less. That is a cross-subsidization. That's not really considered risk pooling. So if you're, think of these numbers as a decade. Let's say at 30 you get sick. They risk rate you. They say, okay, given your lifespan, the chances of you, from your age, from your family history, from your lifestyle, we figure out what we think your how much you're going to spend on unpredictable large item health cares. And then we'll divide that up. So you're paying a little bit at a time. This provides you with some liquidity. You don't have to self-insure for that. But you might get sick at 20, you might get sick at 70, you might never get sick. But if you get sick at 30, normally if you didn't have insurance, you wouldn't be able to pay for it. So all these other people who are in the same risk thing are pooling themselves so they can help pay for your illness at 30. And you haven't had to self-insure, right? So that's what risk pooling is. Similar risks, you come together and you're sharing that risk together. But you don't have to save for all of that expense. And you can have access to that money earlier than you would have if you were trying to save it just throughout your whole life. Go ahead. So the opposite of cross-subsidizing is consumer choice and competition. These cannot work at the same time. We have, when you put in place something like community rating, which says you can't risk rate, you have to charge each group kind of within, smaller definitions of groups, the same risk. That means that you can't have competition. If you allowed competition, cross-subsidization would not occur. That's why we have to have the mandate if we're going to make the ACA function. They have to force the healthier, younger people to pay more so the sicker, older people can pay less. If competition was allowed, then insurance companies would say, well, I'm going to put together a product, I'm going to put these people into a group where they can have lower premiums, and don't compete them away. So this is what's called adverse selection, and then you get these sicker people paying more, right? So they have to force it to be this cross-subsidization. The problem with that is, how do we get innovation? How do we get more value for less money? How do we get increased efficiency in the use of our resources? How do we get better quality? It's all through competition. So if you eliminate competition, you're actually getting rid of the best way that we have for cost control in ways that are important to individuals. Right? So they're opposites. Community rating, skip, we'll just keep going. Guaranteed issue, I'm running out of time. Individual mandate, one big risk pool. Other ways that we've made healthcare more expensive artificially is by the states mandating benefits. These, and within the ACA, it's the essential benefits. If you're going to buy insurance, you have to buy a Cadillac. You can't buy a Volkswagen, right? And again, all done with the idea of trying to protect patients, trying to make sure they're getting a quality product, but the higher quality product costs more. And when you do that, you price people out of affordable health care. Just like when you raise the minimum wage, and that's a big topic going on right now, it's just uncontestable that if you raise the minimum wage, you increase the amount of unemployment. You do. Now, it may not be across the whole economy, it may be only in young black men, but you will increase unemployment. Same thing happens if you increase the standard, if you create a minimum assurance that has to be purchased, you will also increase the number of the uninsured. And I think a significant portion of the presence of the uninsured in our current economy is because people are being priced out by these minimum insurance laws. Next. So just a quick to show you that in following Medicare and Medicaid, and then really took off after we let go of the gold standard, we saw inflation take off. This is the general inflation and medical inflation way above it. There's a gigantic amount of money that was infused into our economy through Medicaid and Medicare spending. The benefits, there were a lot of people who had access now to health care that did not have it prior. But you had more dollars chasing the same supply. In economics, that means prices go up. So people are getting priced out. We as people that care about other individuals say, how are we going to solve this? So we come up with subsidizing health insurance. Medicare is subsidized coverage. Medicaid is major subsidized coverage for people. We're doing it because we care about people, we want them to get access. But what happens is, oh, and the other thing that subsidizes health insurance, of course, are those tax deduction, you don't have to pay taxes on your health insurance premiums if you get it through your employer. So people are less sensitive to the cost because they're getting huge discounts or free health care. But hospitals are going to respond to that infusion of demand by expanding their services. Well, government doesn't like all this, what it's spending, so it starts cutting back on how they're paying and what they're paying for. Well, that makes hospitals congeal into bigger, massive systems. Doctors congeal into bigger, massive systems. Insurance congeal into bigger, massive systems. And depending on who wins, who is stronger locally, you've got different drivers pushing up costs further and further. More and more people are getting priced out of healthcare because it's more costs are going. So premiums go up. Health insurance becomes less affordable. And then what's the typical answer? Let's increase the subsidies. So this is what I call the second death spiral that we're facing, where we're just going to keep driving our costs higher and higher until people will cry out, well, we have to have the government take over the whole system. So what we have is a huge medical industrial government complex. And regardless of what you think should be the major provider of healthcare, whether it's markets or whether it's government, we need to look at what are the different effects that the interventions that we're having on that whole system, and figure out ways to deal with it. Go ahead, next. So this square here was the bureaucracy prior to the ACA. Medicare and Medicaid. That's what the ACA creates. People are saying it's going to be more efficient, more cost effective. I have real concerns about that, particularly because the division between the physician and the patient is getting further and further apart. The goals of real healthcare reform should be affordable access to quality medical care. I think we want informed patient self-determination. We want to empower patients to be able to make the decision that makes sense in their individual circumstances with the resources that they can muster on their own, and certainly make voluntary assistance available. And in our current system, because all these government interventions have priced people out, I don't think you dump all the people that have become dependent upon government subsidies, but we do have to find a way to ratchet that back. They're the biggest victims of government intervention, the people that are on Medicaid, seniors who cannot, there is no private option to Medicare. And we can't dump them. So there needs to be a way to transition, to give them a chance to start saving, to start thinking in terms of ways that they can take care of themselves. And we want voluntary exchange on a level playing field. That's what a free market is. It's a level playing field. People think of free markets as a way that companies can lie, cheat, and steal. That's the antithesis of a free market. You can't lie, you can't steal, you can't, I mean, business school, right? How many business schools say the way to become a really successful business is to lie, cheat, and steal? Screw your employees, cheat your customers, rob your suppliers. That's not the way that we create value and a successful company. A few, like Enron, might make it, but they don't last. And there are a few, because there are crooks in the world, and that's why we have government, right? To try and catch people and punish them when they do lie, cheat, and steal. But a market as a system is not set up to empower those people. Much of that much of that cronyism allows when we create that government industrial complex that allows special interests to create special favors to themselves. Okay, what's next? So what is real health insurance? I think it's catastrophic coverage. I don't know what the market would create. Maybe a lot of people would choose prepaid health care. My in-laws are at Kaiser. It is fabulous. I've been so impressed by Kaiser, and that is definitely a prepaid health care system. They're doing a great job. Doesn't mean that we should transplant that and have one size fits all, and that's the answer for everybody. High deductible, low premium, just like we do for most insurance. That means the predictable things like, well, child checks, maybe even most of maternity care. Sore throats, definitely. Those kinds of things should be out of pocket. You pay for them. And whether we do it with an HSA in a tax protected savings system or not, those are part of that transition. There's risk rating and medical underwriting, equal tax preference. That's the least that we can do, is make sure we're not incentivizing the most expensive, least efficient ways of paying for health care. If it's individually owned, then we could do away with pre-existing conditions. The whole problem of pre-existing conditions is because people get their insurance through their employers. If you lose your job, you don't lose your house or your homeowner's insurance. You don't lose your car or your auto insurance, but you do lose your health insurance. And that is because of that incentive, tax-wise, for people to obtain their insurance through the employer. But what if all healthcare expenditures were treated the same tax-wise? I think the least disruptive is if there's no tax incentive. I don't think that's politically viable. So what we're probably going to need to do is make all healthcare expenditures. It's illegal for an employer to purchase individually owned insurance for their employee. How crazy is that? So what system would work? I get pregnant, I buy insurance for my unborn child. There's no pre-existing conditions. Very inexpensive, particularly if it's going to be for those big cost, unpredictable items. That child turns 18, I hand over that contract with those low premiums to that child, and they carry it with them the whole rest of their life. Right? And then there's a contract that says if you get sick, the insurance company has to pay. If they fall through on that, then they're lie, cheating, steal, and then we go after them. Right? And there's another thing called health status insurance, which was starting to emerge before the ACA, and it'll be interesting to see if it can survive the pressures to have it not be an important product. But health status insurance, you can also think of it as premium protection insurance. It might even be cheaper rather than to contract throughout a life at a set premium. They're going to have, because then the insurance company's risk is higher. They don't know what's going to happen to you. But if they allow your premiums to go up if you get sick, so they're always getting enough premium to pay your expenditures for that year, then you might get priced out of affordable premiums. But if you get the second rider, which is premium protection insurance, this will pay the difference. If your premiums go up, then this insurance covers the difference. So there's all sorts of really fascinating things that we can try and come up with if we have the premise that what we want to work is a voluntary system, a system of competition where we're competing on price, we're competing on quality, and we're creating much, much more efficient things. What do I have? I think okay, we are on the verge of an age of medical excellence if we don't crush it. We are working to get the world out of poverty, not by cost control, contracting resources, top-down control of resources. We are getting the world out of poverty by creating an abundance of resources. That's the way you drive down prices, up quality. And we need to do that with healthcare as well. And yet everything we're hearing is we have to have this top-heavy, cutting, controlling, contracting, somebody telling us, no, we're going to, what's quality and what's not, and then forcing us to not be able to pay for what they don't consider quality. This is hard to see. This is a computer chip in the back of an eye. You guys are probably more familiar with some of these advances. You maybe actually see this. That computer chip on the retina lets a blind person see. That technology exists today. It's outrageously expensive. Just like cell phones were really expensive in the 70s. We can take robotics and make paraplegics walk. Next. This robotic actually connects into the nervous system of this guy. It works on his brain. It's not a mechanic computer. It's his brain that allows this amputee to be able to do it. We've got cochlear implants. We're letting the deaf begin to hear. So crippled, walk, blind, see, deaf can hear. These are really expensive. We're not going to be able to offer these fabulous treatments if what we're doing is contracting, controlling, penalizing innovation. When I went to medical school, it looked like you had an iPhone in your chest if you had a pacemaker. Look what we're doing now. And I find this one of the most exciting things, a handheld ultrasound. What can we do to third world developing countries if we are able to carpet them with this kind of technology? Out in a village, somebody's got a handheld ultrasound. No, we don't have to transport this child who has abdominal pain. There is not an inflamed appendix. Fabulous. I give this talk to seniors. That's a capsule you can swallow and not have to have colonoscopy. So there are solutions. What we need to do is make sure that we're not building obstacles to those solutions, that we're maximizing our ability to create, really let those medical entrepreneurs flourish. And when we have this top-heavy, prescriptions from the top, we don't know what's going to happen. And I would argue that it's less efficient. It's also imposing some small elite group of all, connected people, their values on the rest of us. We can't work with our patients individually and say, and nobody's really looking at what's cost effective, because how can you do that in this massive system? We are so in debt, and Medicare is so close to not being sustainable. It's really not sustainable the way it is, but it's not, completely bankrupt. But we're headed there because people can't make good decisions. There's not really an efficient, effective price system right now in medicine. So that's my spiel. I talked way longer than I wanted to, and less time for questions. But Benjamin Rush is interested and committed to solving healthcare challenges through innovation, through abundance, and making sure that doctor-patient relationship is the most important decision-making part of the medical care system. So we try and have talks like this, discussions, try and make it so that we can we also have debates. Debates sound like it's contentious, but it's really trying to bring people with different ideas together to talk in person to person and get away from this just totally politicized, pointless blah blah that you hear in the politics. So, any questions? Thanks.
Thanks for coming and doing this presentation. I'm sorry I came in the middle of the way, our bus was late. My question to you is regards to output. So you made a mention before of how they're doing a top-heavy kind of cutting. And when you look at economies, that's usually the first thing people think of, right? You need to cut out on jobs and whatnot. But really, it's the output. When you do more production, you get out of that recession. So what do you think would be a way for us to use these great resources in such a way that we were able to increase the production of, in this case, treating patients, but at the same time save money? How would we get out of that recession?
Yeah, and that's a huge thing. It's the whole supply side versus the Keynesians, which is we need demand and all that kind of stuff. And I don't know how to answer that right now, but there are some exciting things. Again, little flowers of fabulous innovation that are going on. I've got some friends down in Florida who have have a family practice, and one section of their family practice is direct pay. So for $89 a month, it's a subscription practice. Their patients get all of their preventive health care, 26 office visits, anything that can be done in the office is no extra cost. At a spouse, it's $69. At a child, 1 through 100 child, it's $50, right? How are they doing this? Well, one of the ways that they've done it is they've gone out and contracted with independent labs, diagnostic areas. He's getting $5 labs, $20 chest x-rays, $300 mammograms. This is a tenth the cost of what they're doing. There's another family practice that's doing it in Nebraska, and they're actually even setting up a pass-through for their medications, because physicians can act as medication dispensers, so they're getting wholesale pharmaceuticals and medications that they might pay at the pharmacy for $100, $200, even with co-pays, they're getting them for $5. It's amazing what we can do. There's a surgical center in Oklahoma that puts their prices online, the Oklahoma Surgery Center. And it's a surgery center, not a hospital, because of the laws, makes it very hard for them to operate as a whole hospital. But at a tenth of the cost, they've got a contract with the teachers in Alaska that will fly the teachers from Alaska to Oklahoma, put them up in a hotel for before and after the surgery, pay for the surgery, fly them back home again, and they're saving money. So these are the kinds of things that if we don't make it illegal. Now, part of the problem with the direct pay family practice guys is they're covering those predictable small items, right, for less than the cost of a cell phone. And what's really fun is I just found out from the guy, Medicaid in Florida is now out of money. They are referring patients to his practice. His major target are the uninsured and the underinsured. And, oh, but so they need catastrophic care, right? So we need to be able to pair that with some kind of coverage for that big price, unpredictable items. The ACA makes that illegal. Unless you work as an employer, and so he's working with some of the medium-sized, like 50 or more, 50 to 100 employee businesses to contract, so they self-employ. Usually it takes something like a Safeway or, you know, these gigantic Ford or somebody big to self-insure. But he's trying to help it make it possible by combining his direct pay with the companies paying for the catastrophic out of their profits. And that might work. But we've squeezed it down to that, rather than letting it really open. Does that answer the question?
I realized there was a loaded question myself when I asked it.
I mean,
It touched base on a lot of the issues. Thank you.
Okay.
I kind of had two. You know, you kind of made some like proposals about like the insurance, and obviously there's a lot of problems with the way like insurance like functions today. But like, I guess kind of being like most realistic as you can, like what would you like to see like insurance like function as like right now? I mean, I guess when I try to think about it, like a real fundamental question is like, you know, you take your average 45-year-old person who has a family and kids, like, you know, how much should they be like interacting with like the healthcare system on like a normal kind of basis in terms of, you know, how much should be doing with their primary care physician, everything like that? Because, you know, it's tough. I mean, this is kind of going, you know, you seem like you're a lot about like kind of like the free market kind of with healthcare. And I mean, I personally, you know, I think there's something to be said about having more free market, but at the end of the day, I think that healthcare has tons of market imperfections within it that just people just cannot really understand and can't really conceptualize in terms, I'm talking about patients. Like, a patient comes into, you know, an office and the doctor prescribes them medications or maybe needs a procedure, like, you know, in a free market, a patient will go, oh, you know what, I don't need that procedure, I don't need that medication, I'm gonna be fine on my own. But that's not how healthcare like works at all. Like, patients are paralyzed in kind of what they're doing just because they don't know what to do and they don't know how to do it.
So that what's called in economics information asymmetry, right? So there's
Exactly.
the physicians know more. Well, so does my lawyer. So does my house contractor. There's a lot of people that I interact with on the market that I end up having to take their word about what's right and what's wrong. And the way our system is set up is that people have become insulated from having to even think about medical decisions. And physicians don't compete on quality.
How do you
Right.
measure quality? That's almost an impossible thing to measure in medicine.
I don't know.
Well, the Surgery Center of Oklahoma is a notable one. They had the nosocomial infection rate last year of exactly 0 versus the local hospital with most of those same.
So there are ways to do it, and and exactly how are you going to compete and what quality measures are important to patients, I don't know. It's a discovery process that works within the market, but part of what it is we've gotten it so that the doctor is not primarily the patient advocate anymore, right? So as a doctor, the way it would work as in a private, I would say I will give you the best quality care for the lowest quality price. And people would come to me, and then word of mouth and colleagues, and there's all sorts of different ways that people can find out quality. I mean, how do you find out quality with any complex issue?
Word of mouth, it's the only way.
Okay, so we would need to do that. The bulk of our healthcare expenditures are not on, you know, okay, I got hit by a car and I need to go to the emergency room. But you know that's a possibility, so okay, do your homework ahead of time. I want a physician that I know I can trust that will help me decide which facilities are going to give me the best care, right, at the best price. A physician becomes an advisor, and then I end up as a physician competing with other physicians to be able to provide the highest quality at the lowest cost. We don't compete like that, right? On Medicare and most insurances, you get paid based on a contract price that's got really very little to do with your quality.
So you're saying that the doctors need to be able like to tell their patients like what procedures they need to have and not have in terms of like, you know, like a morality kind of basis, and then they're competing against each other for that. That seems
If
a little
my
far-fetched,
job,
to be honest.
if my job is to offer the best possible advice to my patient, and that's what I'm competing on, and I end up advising all sorts of unnecessary procedures, in the long run, I'm going to lose.
Not necessarily. I don't know how people will be able to determine those kind of things.
Well, I mean, just like with any kind of like, what's the consumer reports section? There could be consumer reports for physicians that there's all kinds of objective ways to measure these kinds of outcomes, and there are plenty of watchdog organizations that can, the simplest one is, what's this Angie's List thing for plumbers and whatnot? There's complex.
And are they in existence now? No, because there's no demand for it.
It's like, they're scratching the surface, like, they're just kind of beginning to start in many kind of ways and stuff, and like, what you said about the, like, infection rate, like, that's like you'll measure, but that's one small aspect of quality, I mean, and the other, I mean, it's very hard.
So we couldn't leap to that instantly, right, because that information's not there. But if what we're doing is saying this would be a better direction to head, then what we want to do is at least not put obstacles in the way of people who choose to have that kind of interaction, right? So you may choose to want to belong to a system where they're making all the decisions and they're controlling the physicians. There may be other people that want the opportunity to say, I want to choose for myself who my physician's going to be and what I'm going to pay them, and I want that ability. And what we're doing, though, in the system that we have is we're making that not even a possibility. That's my concern. So who's going to win? Which system? I don't know. But let's give it a level playing field. Is that?
So, I mean, I don't know, like, it's kind of hard to think about, like, people kind of interacting that way. It's just, it's not what happens, like, right now at all.
It's not what happens now.
It's
Absolutely not what happens.
close to what happens right
It's
now.
absolutely not, because incentives are not what drive.
No, and I completely that's why, like, a big thing I kind of always kind of talk about with people and kind of dabble with is kind of like the concept that, there's all these, it's like an 80-20 kind of role with like economics. It's like 20% of the population is using up like 80% of the resources. And a big thing that I kind of think about that is like, okay, we need to take these 20% of the population that's using up all these resources and we need to really kind of cost control them. And so like you almost need like these big hospital systems to almost cost control. And that's why like I actually kind of go the other way. Like I think that the government the hospital should almost be like bidding on these kind of patients and stuff. And like, they have to control like what is used with these patients and stuff like that. And if they can save money on the patients, they can pocket that money. And if they can't, then it's, then they're screwed with that. That's where they have to kind of make the decisions.
And the concern I would have is the question is, who's the ultimate consumer right now? We have people, you've probably heard third-party payment, that's what we have. I would say it's fourth-party payment because most people aren't even paying their own premiums, right? So we've got this huge insulation of the patient and the doctor from actual cost considerations. We can't make decent, cost-effective value decisions based on that. And so the only thing that we have to make up for that is this top-down way. I mean, that's the way it is. But then what you're doing is you're taking away patient control. You're taking away personal value choices. You're not empowering patients. You're not building a system that will empower patients to be able to make the best decisions that they can for themselves. You're saying we're going to let somebody else do all that. I think that's less than ideal.
I don't know.
I got to move on to some other questions, but it's great. I mean, this is great because I think many people think the way that you do, and I think that's why we were at. And you raised some really important obstacles to where I want to head.
So what about the poor? Because I see a primary goal of the ACA is wealth redistribution from the rich who have
Yes.
too much to the poor who are dying of preventable diseases.
That's a
And
problem.
so how do you deal with that in this model?
Okay, so how you deal with that is you accept the fact that those poor are where they are right now because they've been priced out of affordable living. And they've been priced out of affordable living by these well-intended interventions that are saying you can only buy and trade at a certain quality, okay? So I think they're the biggest victims. Now, what they did in Indiana was Healthy Indiana. They created a Medicaid system that was based on and I think this is a great transition thing, where they will pay, Indiana pays the catastrophic health insurance costs. Big items, it's real insurance, okay? They fund their HSA. It gives those people access to those cheaper, more predictable things, and they're learning how to budget. They're learning how to, it's empowering them to learn how to be able to function independently. So I think that's a transition of what we can do. I think the ACA, it could be in transition, except what it's going to do is drive us in that whole death spiral again, where it's going to make it more and more expensive. So if we, again, can at least not prevent and make illegal those options, that I think will actually end up driving cost,
So you accept
while
the
we're
need-
taking care of the people that have been priced out of affordable health
So you
care.
accept the need for cross-subsidization and wealth transfer.
Right now, yes.
Thank you.
I would, because I think we've created the system that mandates it. which I think is a tragedy that didn't have to happen.
If you could just do a little mental experiment, what you said was great about this idea of true health insurance, where it's catastrophic care, and when it's not in control of the person who owns the insurance, then the insurance will pay for it, and that the doctor and the patient have the ability to then make decisions about what care is received. If you could just do a little bit of mental sort of gymnastics to see, right now we have this big problem of health insurance companies, in air quotes, denying types of procedures and so forth on the basis of their sort of, deciding whether or not it's necessary.
Mhm.
How do you deal with that? How do you sort of keep physicians accountable and yet still keep the health insurance companies actually paying out when it's a necessary procedure? Because I think one of the biggest problems that doctors have is they hire office staff to deal with these problems, and this is a huge
One
problem.
of the ways is that you, by making it a level playing field, and then people start paying for most of the first dollar coverage, office visits, immunizations, well child, sore throats, those are short acute kinds of things. They start paying for those out of pocket. Then the insurance company is not having to process all those claims, right? So that brings down costs significantly. We don't have grocery insurance for a reason. And yet hunger, food, you need food. And because we don't have grocery insurance, we have a plethora, a variety of different quality people offering food. So we bring down the costs by that. Then insurance companies end up being true insurance companies. And they then don't have to spend all this money inefficiently on these low-cost items. They become better at and more well-funded to actually fund those catastrophic things. The other false assumption that people make is that insurance companies deny care and governments won't. Right? We have limited resources. Somebody has to make a decision about how those resources are going to be used. People will die for lack of resources in a government system. People will die for lack of resources in a free market system. You don't escape that, no matter what system. Now then it comes a matter of how do you think what is your definition of a fair distribution of resources? Who owns those resources? Who gets to make a decision about it? And this is where there's a big divide. I'm still struggling to try and understand better people who disagree with me, and also be understood by people who disagree with me, in the hopes that we can find some middle ground where we minimize the number of people who fall through the cracks. Because I don't know about you guys, but I went into medicine because I love people. I want people to achieve their absolute maximum in their life. It is such a privilege to be a physician. The flight over here, sitting there on my delayed flight that got me in at 2 in the morning, but somebody on that plane ended up having chest pain. Come over there and shortness of breath. Is there a doctor on there? It's like, oh, I really wasn't up for this. And it's like, oh, I've been out of clinical medicine too much. So she was somebody who was 2 days post-op from a gastric sleeve operation and hadn't had any pain medicines since she was discharged from the hospital that morning. Here I am trying to listen to her lungs, to her belly, and I can't hear a thing over the, they got to a stethoscope, but I couldn't hear a thing. Somebody afterwards came up, oh, you were so calm. And it was like, you know what? It feels so good to be able to have that skill to offer and to feel like, okay, I'll do what I can with the resources I have available to me at this moment, which weren't very much. And when we landed, we were half an hour away, so when we landed, they just had the paramedics come. And she had with her her hydrocodone, and I said, well, why don't you try taking that? Because her belly was soft, and she had good color. And by the time she got off the plane, she was breathing easier. We put some oxygen on her. It was amazing. It's such a privilege. It's exciting. You guys are really, I hear doctors say that they would never tell anybody to go into medicine. Oh man, I wouldn't trade it for the world. We have that privilege. And I think what we want to do is make sure that that continues to flower and progress and have these kinds of discussions. We are on the same side, I guess, is the main thing. And I think that gets lost in a lot of the political brouhaha that's going on. And as physicians, even if we disagree politically, we still are on the side of patients. And here's my one patient, which is my mother-in-law. I'm gonna tell her, hi, I'm almost done with my talk. Can I call you back in about 15 minutes? Okay, thanks, bye. She's a perfect example of how we can make better cost decisions if you actually have to pay for your medicines. She has had atrial fibrillation, new onset at the age of 91, and ended up having to be anticoagulated for it, which meant she needed to go on Coumadin. That was the first choice. It's really cheap. It's well known. But at 91, she can't keep her diet straight. She kept thinking, oh God, I can't eat any salads. Because vitamin K would be in leafy green, and it meant frequent getting blood tests and modification of her medicine dose. I was on the phone with her multiple times a day just trying to say, no, this is the dose that you take today. So she has the resources to be able to say, I'm going to take Eliquis. I'm sorry, I don't know the generic term for it, but it's a medicine where you don't have to monitor your INRs and you don't have to watch your vitamin K intake. It's going to cost her a couple $1,000s a year, but life quality for her, it's worth it. Somebody else who can't afford it is going to have to substitute dealing with the fact that Coumadin's cheaper. But until people are actually making those value judgments based significantly on their own resources and their own values, we're not going to figure out what the most cost-effective way of treating somebody is. The most cost-effective way of treating her is not Coumadin, even though it's the cheapest. So it's 12, and I'm glad to stick around and talk as long as you guys want.
Oh, I just was gonna add, like, I think that whether you're on the side of the government paying or private, third parties paying, like, you made an excellent point, which is that there's so much waste in the system, there's so much, I mean, as someone who, I used to do medical billing and, send back, claims to Medicare 3 or 4 times trying to get $70 and like the amount of money wasted, on their side, on my side, like the doctor paying me, Medicare paying the person that stamps denied and sends it back, like, it's